Assalamu alaikum and good afternoon, everybody. It is a great pleasure and a great opportunity to meet our colleague here at King Khalid Eye Specialist Hospital, and it gave me also a great honor to introduce a senior colleague and a senior cornea specialist in behalf of Dr. Nora. She's supposed to be the moderator of this grand round, but she was held in King Abdulaziz because she was having a meeting. So it is a great chance to present Prof. Abdulrahman AlMuammar. He is the senior consultant and professor of ophthalmology and cornea specialist. He used to be the CEO of King Saud Medical City, and at that time he was withheld from the ophthalmology for a little bit, at least the academic lectures, but he was running his clinic and teaching the resident and fellow efficiently, even at the time when he was holding a major administrative role. Now, Prof. Abdulrahman AlMuammar is the head of the Excellence Center of Research at King Saud University, Department of Ophthalmology, College of Medicine, and he's known to most of us as from among the earliest graduate from Canadian program and fellowship, and then he practiced his ophthalmology in King Abdulaziz University Hospital, King Saud University, and today he will present to us a very important topic, especially nowadays with the presence of a lot of patients who underwent a previous refractive surgery. So now some of them, and maybe in the future also, they will have patient who is having cataract who underwent a refractive surgery. And with the era of different types of IOL, Prof. Abdulrahman, he will tell us what are the best choices in certain type of patient, either the multifocal or EDOF or other premium IOLs. And I'm sure this will be an interesting talk for everybody. Please welcome Prof. Abdulrahman.
السلام عليكم ورحمة الله جميعا. 2 points, and I wish I can answer the question, Prof. Abdullah. The more I read about this topic, the more I think become more confused, because I think there is a lot of questions that we look for an answer, but unfortunately most of the evidences until now does not address the issues very well. But it is true now. We are in the era now where people who did refractive surgery in the between 2000 and between 1990 to 2005 are the age, are now approaching a presbyopic age, and most of them who ever had already cataract, or maybe they're looking for a clear lens extraction, are going to seek presbyopic IOL correction. So the question that we face every day now when we are in our clinical practice, and how can we address this issue? My personal experience was as follows. I mean, before, I don't even offer a multifocal IOL for a patient who did a previous refractive surgery until maybe about 2021. And the reason I wasn't offering the IOL at that time, mainly lack of evidences, the main concern that we have of poor expectation, night vision problems related to the dysphotopsia, unpredictable IOL calculation that we might face when we place IOL in such patients, as well as the safety and the rate of complication that might require IOL exchange. So myself and I think other colleagues were also thinking in the same way, until actually I was treating a 60-year-old gentleman who is CEO of an investment company, very well educated, did refractive surgery like about 2010 or 2000 or before that. He was a high myope, -9 and or -10, and he came to me, and at that time he came with a cataract, and his visual acuity was about 20/60, and he said, "I want a multifocal IOL." So that's period. Okay. I meant to discuss with him all the issues and all the concerns that I have with the multifocal, and the chances that we might have either poor predictability of IOL calculation in his case, or may lead to a IOL exchange, especially that he's a very active person. He drives at night, and he has a full schedule of different activities. He likes sports. He said, okay, I'm willing to take the risk. We did the surgery. We implanted the multifocal IOL 1 week apart between both eyes. And he is 20/25 almost at distant, 20/20 at near, very happy patient. And that's experience made me rethink again, maybe I'm not offering my patient all the best solution, because still I need to, when you treat your patient, you want to tell them all the options that that's available, and you can address your concern with every single option, then you can take the decision together. The worst thing that when you have an option that it is valid and it is doable, and you don't offer it for the patient, because some of them will come back to you and blame you. Why you did not tell me that this option is available and I can pursue that. In general, multifocal went through different evolutions, started from being the refractive to the diffractive types, from the bifocal to the trifocal to the quadrifocal to the hybrid product. In general, multifocal works by developing multiple focal images, and it depends on our brain to suppress some image and focus on one and most clear image in order to have good distant and near vision. The problem we face now, when you look into available IOL, there is about 11 products available now for different multifocal IOL in the market. And every month or every, let's say, I'm exaggerating, maybe every 3 months or 6 months, there's a new product that comes to the market, to the limit that you cannot catch up. Yani, the moment that you learn about, or you're trying to develop experience with one multifocal, there is a new generation of multifocal, and then people will shift to the new developed multifocal, and gradually, by looking through, and if you want to try to develop experience with one specific multifocal, you will face a lot of problems, a lot of difficulties. One of them, that you either change your practice and you go with another IOL, or maybe there is a lack of evidences, because every time people are trying to build a good case series in order to report and to share, they shift to another type of IOL, and that will limit the sample size, will limit, the outcome. So this is a challenge that we are facing, and as I don't know for how long it will continue, but as long as we are going in this waves of a new generation of multifocal IOL, I don't think that we are going to reach to a right answer to address our concern. But as I did the literature review, my first question was, is multifocal IOL safe in patients who went through laser refractive surgery? It was not easy to answer, because every time you look at a report, most of the studies done to address the multifocal IOL in people with brevis are retrospective in nature. And when you look at how the methodology they use, they go and retrieve all the files of the patient who did the refractive surgery. Then they start to select the best candidate. They will exclude, say, for example, people with cornea. They will exclude people with retinal problems who underwent the surgery. They don't report them, unfortunately. They will exclude people with higher order operation. They will exclude people who has any IOL complication, decentration, or poor predictability. Then they start to report their best outcome, And there was consistency in this behavior in most of the reported literature, which made it also difficult in order to come up with a fixed consensus regarding what will be the safety. However, reports of the safety in terms of losing best corrected visual acuity is quite different. If you look at in the myopic group, about 0% lost one line, about 11% lost, 0% lost 2 lines, 11 lost about 1 line. But when you look with the population who has myop and hyperop, the percentage will increase to about 21% for the 1 line and 5% to the loss of the 2 lines. The variation that we have in the selection make it quite difficult to address if the multifocal is really safe, and what do you tell patient in terms of the chances of losing best corrected visual acuity. I tried also to look what will be the outcome parameters that we look in terms of to address the multifocal. Mainly uncorrected distant, uncorrected intermediate vision, uncorrected near. Papers that looked at the myop and hyperop found that about 46% patient will have a 20/20 vision for the distant, and about 81 will be able to read J3 without the glasses. This is when they test as a uniocular. When they do the binocular vision, actually the percentage will increase to 67% will have excellent vision at this interval, and 85% will be able to read without any aid. Other papers, okay, found quite, but with a large variation. In the first paper here, there is among myopic LASIK, there are about 35% who were able to read without glasses. In another study, the percentage actually increased to about 65%. So as I was searching the papers, I found also the results is quite totally different, from 35% of people who will be able to read without glasses to about 81% of patients, which make it also quite hard when you tell the patient what will be, okay, the chances of being spectacle free for near. One good study actually, where they actually looked at three cohort of patients, patient who received multifocal, patient who received EDOF lens, and patient who received monofocal. And they measured basically patient satisfaction per se through a questionnaire, standard questionnaire that they distribute among the patient. In such cohort group, people who received multifocal scored the highest satisfaction, which was about 85%, decreased to about 76% for the EDOF, and less than 40% for the monofocal group. Now, what about complication, reported complication in patients who received multifocal? Most common complication encountered in people who receive multifocal is the dysphotopsia related to the photic phenomena. What is the percentage of patients? Again, there is a variation in the reported figures from the literature, going down to about 5% of people who might have a glare, up to a percentage that can reach to 57% and 70% of a glare. So such variation is mainly related to that the way they were measuring the glare is totally different. Some of them, they just by asking questions, some of them they do a more multiple questionnaire, and they try to address if the patient is suffering from the dysphotopsia. However, even though people reported having dysphotopsia and night vision problems, the correlation with the visual outcome and the satisfaction, as well as the spectacle independency, was extremely low. And you can see patient who has dysphotopsia, but still that his satisfaction will be high and he will be able to function and become spectacle free. Same thing for contrast sensitivity. We always address contrast sensitivity when we look at the multifocal IOL or EDOF. Again, there is most of the paper would agree that there will be decrease in contrast sensitivity among patients who receive multifocal IOL. But the good thing that the correlation with the final outcome in terms of being spectacle independent, in terms of the visual acuity for distant, intermediate, and near, that was extremely poor, and that usually does not affect the final outcome. How about laser enhancement? Multifocal IOL has very low threshold for any refractive error. Minus 0.25 of myopia can lead to unhappy patient. And okay, we always accept, we don't even treat minus 0.25 in patient after cataract surgery or a normal situation. But if you implant a multifocal IOL in a patient and he comes with a quarter of myopia, expect that he will be suffering from decreased distant vision, and also he will be quite unhappy. Even the minus myopia will not help him for near vision. So about 20% of patients who actually go for multifocal IOL after refractive surgery might need a laser enhancement surgery to address the refractive error following the cataract surgery, which is higher also than when you compare it to monofocal group usually. Is the YAG capsulotomy? Again, our threshold for PCO when you use multifocal is much lower. We can tolerate mild, even moderate PCO in normal situation for monofocal, but with multifocal, no, our threshold is low. Again, about the percentage can reach about 13% of people who may need a YAG capsulotomy. There is no study compared to a monofocal group in the same population who received refractive surgery. In general population, we might see about 4%, and sometimes the studies can reach up to 10% of the people who may need YAG capsulotomy. To my surprise, the IOL exchange, I was so expecting when I review all the papers that I will see at least how many people who request IOL exchange to get rid of the symptoms, and it was not reported in about most of the studies that I reviewed. And I think one of the reasons that they were not included, they were immediately excluded once they start to report the papers, which actually address the issue that evidences we are using is quite weak and it's not enough to build consensus and to be the best practice. There is a general agreement that usually best people who fit for multifocal after refractive surgery are people with low higher order operation for the 4 millimeter pupil and 6 millimeter pupil, which are about 0.3 to 0.5 millimeter. However, this hypothesis is based on people experience, is not an evidence-based, is just a suggestion of a different group of panelists, could be company-driven or could be from a group of experts developed or actually assigned by different society who can come up with such recommendation for the cutoff limit for the higher order operation in people who will undergo multifocal IOL. Angle of kappa, angle of alpha. I always hear about how important such indicators for selecting our patient. When I even searched on all the papers published, that for the angle of kappa, actually, most of the reported articles, they were trying to select people who are maximum is about 0.5 millimeter of angle of kappa. But in the other hand, there are people who looked actually that the angle of kappa actually will decrease even more after phacoemulsification as the pupil actually will constrict usually after cataract surgery. And as we get older in age, also our pupil will get smaller, which means that using the angle of kappa as an indicator might not be very helpful because there is already changes will happen in this angle after we do the surgery. Angle of alpha might be, which is the differences between the visual axis as well as the optical axis of the pupil might be a better indicator, and they are using it now for the 0.5, 0.6. But the good thing now that most of the IOL design that we have for the multifocal IOL, the inner circle of the IOL will usually about 1 to 1.2 to 1.5 millimeter. So if the angle of kappa does not exceed the half the diameter of the inner circle, then it's unlikely this angle will affect the final visual outcome. Regarding the predictability, most of the reported paper, they used the Asker's IOL calculation for post-refractive surgery with very good predictability, and this was reported in about 80 to 90% of the paper published addressing the multifocal IOL in post-refractive surgery. Is the pupil size is important in multifocal IOL? Again, there is maybe a few papers who address the issues of the pupil size. There is agreement among the panelists that if you want to select patient, it should should not be more than 6 millimeter for the scotopic pupil, and it should not be smaller than 2.8 millimeter for the photopic pupil. However, again, this is not an evidence-based. This is based more on a recommendation of an expert people who think that this will be the appropriate range of the pupil size. Most of the paper also will do agree that according to their selection criteria, will avoid people with corneal diseases, will avoid eyes with severe dry eye, irregular astigmatism, uveitis, glaucoma, macular pathology, and people with unrealistic expectation, and people with abnormal psychology. As such patients, usually you may end up with poor result and being unhappy. Okay, and this is, I think, will lead to a poor satisfaction. And from my experience, I think most of the patient I see in clinical practice who are unhappy with the multifocal IOL, if you look at carefully, you will find that one of the list here is applicable to him and it should be addressed before surgery to avoid such complaint. On the other hand, the new generation of a presbyopic IOL, which is the extended depth of focus, which mainly instead of developing multiple focal images, it will be okay as a linear images and also depend on the brain to suppress unwanted images. In the current practice now, there is about 18 products now for the EDOF lenses. Again, every month or two, you will see a new product with this high range of evolution coming in the lens will make it even harder for the EDOF actually to come up with a consensus among the studies that done to look at the EDOF lenses. I did not find any paper to address the safety of EDOF IOL. I don't know, maybe because it was very safe, so that's why they did not actually look at it, or maybe actually it was not measured or not looked at. In general, about 52% will have a good near vision, 100% will have good intermediate vision, 92% usually satisfaction of the EDOF lenses after refractive surgery. And one study also compared EDOF versus monofocal group of patients who underwent myopic LASIK. They categorized them into monofocal versus EDOF, and the EDOF lenses actually was superior in the intermediate and near vision, as well as the patient satisfaction when you compare it to monofocal IOL. Complication rate with the when EDOF was developed and started to come to the market, the main marketing tool was that there is a less glare and halos with it. However, studies also looked at that there was about 20%, which is less than the multifocal IOL, but still there exists as a night vision issue. However, does not affect the clinical outcome at the end. Contrast sensitivity is similar. There is a decrease in the contrast sensitivity, but again, it does not usually impact your final clinical outcome. Laser enhancement is still seen after EDOF lenses, and one study also that addressed laser enhancement, 9 of them actually needed a laser enhancement. About capsulotomy rate was not reported in most of the studies I searched, as well as the IOL exchange was not even was not addressed. And I think that might be also either from their selection criteria or inclusion criteria, or because it is extremely low to explant EDOF lenses. Angle of kappa, angle of alpha, still they are applying the same concept of being cutoff line of 0.5 to 0.6. However, EDOF is more forgiving for the angle of alpha. Even I think with larger one, the patient can tolerate EDOF lens without the visual difficulties in terms of the night vision problems. Are there differences between myope and post-hyperope? Two studies looked at this fact in particular, and that they found that the loss of corrected visual acuity was bigger in the hyperope group versus the myope group. And this might be related to the changes that we have in our cornea after hyperopic surgery. However, in terms of the final visual outcome, they were quite similar between the two groups. There were differences in terms of the laser enhancement, as well as there is more laser enhancement in the hyperope group, as well, and there is also for the capsulotomy that was more in the myopic group. In conclusion, safety, we consider multifocal IOL and EDOF can be very safe if you select the right group of patients. Your selection criteria and patient who has refractive surgery done should be more strict. And I think especially with the higher order patient, and especially also with the cornea pathology and the dry eye and the K reading. Having said that, still it's not an evidence base, it's more like based on our experience. In terms of the outcome, multifocal IOL and EDOF are superior to monofocal in terms of especially for intermediate and near vision, and multifocal IOL is superior than EDOF for the near vision. Rate of spectacle independency in general is very high for both the multifocal and the EDOF lens. In most of the paper also will agree that multifocal will be quite superior by 10% for the patient satisfaction and spectacle independency. In general, EDOF also is known to have a lower dysphotopsia rate in patient post-refractive surgery. However, even with the dysphotopsia rate that can reach about 50%, there is poor correlation with the final outcome. Contrast sensitivity in general, it is decreased with both multifocal and EDOF, with poor correlation with the final clinical outcome. For multifocal IOL, when we want to address patient who receive refractive surgery, the recommendation that currently now quite applicable in most of the practicing ophthalmologists is if you want to do multifocal IOL, best-corrected vision should be better than 20/40. If you put multifocal IOL in a patient who has best-corrected visual acuity less than 20/40, expect that satisfaction will be not as good as you might think. It's better if you have the K reading between 40 and 45. However, this is not an evidence-based. The pupil range is good to follow if you want to at least become on the safe side, as well as the root mean square for higher order operation will be less than 0.5. avoid people with corneal diseases, irregular astigmatism, dry eye, uveitis, glaucoma, and macular degeneration, as well as the poor expectation. Prior laser patients who received hyperopia are more likely to lose best corrected visual acuity. So if you see that patient and you decide to do a multifocal IOL, you better address this issue. It might be safer to use EDOF in patient who has hyperopia rather than doing a multifocal IOL. In general, if you expect poor IOL predictability, better to go with the EDOF, as the EDOF can tolerate differences or unpredictable error, rather than multifocal, whose the threshold for any deviation from the predictable IOL, predictable refraction can affect their satisfaction. Patient with retina pathology or glaucoma, it might be safer. It might be for the patient interest to avoid multifocal and to use the EDOF lenses, as the effect in terms of the measuring Humphrey visual field as well as the satisfaction, it could be a bit better in such group of patients. Overall, the weaknesses that I have faced when I was researching in this is that no prospective clinical trials. There is also difficulty comparing between different paper and different studies, as there is no standardized method for inclusion criteria, no standardized method for the outcome measured, no standardized method actually for the way they are measuring the outcome. And when they do the analysis, the problem, they are using different IOL. Every time they introduce a new IOL, they go on and develop a group of patients where they actually implant the IOL, which make it harder also in order to compare different IOL, as the design and as well as the concept will be quite different. In general, most of the paper published in this field has very small size, which is also will make it difficult to build evidence-based practice based on the study reported. Mini vision and mix and match approach in post-laser refractive surgery is not yet addressed, and there is no reported papers, according to my knowledge, that can address the impact of mini vision and mix and match approach in patients after laser vision correction. And thank you very much.
Thank you, Prof. Abdulrahman, for this nice grand round and to the point take-home messages. Now we will open the floor for discussion. I'm glad that you left some time for discussion. I'm seeing a lot of our colleague here, either refractive surgeon or cataract surgeon, that they will influence also the discussion.
Thank you very much, Prof. Abdulrahman, for a very nice and informative lecture. Actually, when we start refractive surgery in the past, we were thinking about calculation later on, and we are sure we face this problem later on, which is true. Then with improvement of technology and machines and topography and all these things, calculation and formulas, things getting better and better. And nowadays, all people, they are looking for far and near vision, which is now with the multifocal, and EDOF is getting my things. It's important to be clear with the patient and explain to him things, because if you don't explain before surgery, he will bother you all the follow-up and all he never convinced later on. And one of the enemy for multifocal, for the EDOF, is the dryness, which we have it here. Most of the people, they have dryness. The other things, with the use of electronic devices, almost all people, they are having dryness. So at least to make sure the dryness is treated well, and especially in the first 6 weeks, 3 months, till the patient gets adapted to the new lenses. My question, I don't want to make a long comment. My question, which one you prefer? And even those which you mentioned during lecture point 25, if you treat patient well with lubrication, and they will accept it and they will be happy, it will help them more for near. But their main problem, which most of the time, and the other thing which I want to make it clear, people will depend on just only drops. Drops will not work. lubricating drops. It will be inhibiting the normal secretion. So usually I use in the first at least 6 weeks or 3 months, I use ointment at least twice a day before sleep and when he wake up. So it will make smoothing of the surface and make the conversion of light easy to the macula and minimize the glare. Okay. The other thing with post-hyperopic patient, laser, they usually, whatever you do, they have complaint. And type A personality. Type A personality, everything is good and he still complains. So I think it's important to be clear with the patient and to select at least those. He's keeping asking, making, this is type A personality, uniform convention. Thank you very much.
I totally agree. There's a lot of an open question that we cannot answer. And I personally now choosing a multifocal IOL, if I give you now an answer, I might change it in 1 month from now. Okay, because usually we are driven by maybe opinion of our colleague who used the one IOL and he is happy, or an opinion of someone who presented his lecture in any of the meeting, or the cost. The cost sometimes can play a role in terms of selecting the best IOL. Up to now, and I don't want to say this is not a beyond marketing for the PanOptics, okay, for the multifocal IOL and the Schedule for the EDOF IOLs is my preference. However, this is just based on personal experience and has no evidence. I have a colleague who doesn't use them both because he's not happy with both of the IOLs, okay? And just tell you the house variation. Totally agree with you for the dryness. I totally agree with the hyperopia. Patient will keep searching, even though you counsel them. I think there will always be that consideration. And if you balance it, would you give them the option or you don't give them the option? And I think at the end, I think we should give them the option. We should tell them about all the risk and show them about all the chances. Alhamdulillah, I did not have to do exchange until now. Okay, I have an unhappy patient, but we did not reach to the exchange until now, which tells me, because some of the people who were persistently complaining that they are not happy, when I go that far, I say, okay, let's plan now for exchange, they stop. Okay, and they said, okay, we'll live with it, but rather than just, okay, having it explanted. Thank you, sir.
Thank you very much, Dr. Abdulrahman. I have 2 questions. The first one regarding the tinted yellow lenses and the clear lens. Have you noticed any difference in the visual quality between the 2 lenses? And the other question regarding the selection criteria, you mentioned that keratometry is between 40 and 45. And you know that many patients post-myopic refraction, they have less than 40. If the cornea is regular, would you consider the multifocal IOL?
Okay, great. Now, with the tinted IOL, I personally did not see that differences, and I have patient actually who I implant tinted in one and not tinted in in one eye, and rarely. But there are specific patients who are extremely smart and who can pick such a differences in their circumstances, and usually most of them actually with no refractive surgery done. Now, I totally agree with you. The patient I have done, I'm reporting, he was 36K reading, okay? But what I listed here is this is the best recommendation brought by a group of experts, okay, who actually develop a consensus regarding what will be the best practice to be in the safe side. But we see hyperopic patient who is more than 45. We see myopic patient, usually most of them below than 40. If the other criteria, okay, does not go against the selection, I will go for it.
If you allow me just to comment on these 2 topics about the flattening of the cornea. And Dr. Saeed mentioned also the post-hyperop. At least in my practice, I usually look for the topography. In my opinion, the topography is the guide for which IOL you will go for. Even if you go to the extreme one, the post-RK patient, and to the simple post-myopic patient, if you see the topography is good and regular, mostly they will be happy with the lenses, whatever your choice.
No matter what's the higher order aberration?
The higher order aberration, usually it will be reflected partially with these topography changes. But I mean, if you see smooth cornea with topography, al-ghalib minhum, they will be fine. In my opinion, I usually go for monofocal plus. in those cases, not because of the inefficiency of the performance of the lens, it's because of the predictability of our IOL calculation, which you mentioned in the introduction. And here we have also a problem that you cannot pick up the lens that will get you to the emmetropia or slightly myopia. Mostly, or at least a considerable amount of cases, they will be overshooting or undershooting. So this is why I think monofocal plus and then managing to go do a match or mini monovision, at least this is my practice in those cases. But again, to be accurate, also you will choose some of the designed lens that will compensate for this asphericity, which the doctor alluded for, to have a flat cornea or which is post hyperope or post. Yes.
Thank you very much, Prof. Abdulrahman, for a really interesting topic. When tackling the residual refractive error, especially in trifocal, if you have, like, as you mentioned, a quarter of a diopter, sometimes it will be very difficult to correct it with a laser vision correction. And sometimes even it becomes even more difficult if you implant a toric IOL with mild off-axis, which induce some astigmatism, not in correlation with the corneal topography. How would you tackle those patients if they have whether slight off-axis or mild residual myopia?
Yeah, slight. For slight off-axis, I might address with the laser enhancement, but the problem is the quarter myopia. That sometimes most of the laser machine will not treat it. And you are more likely that you might end up with overcorrection. So I have one patient who's she's an academic staff, and she's a professor, and she likes to read a lot, and she's kind of for the multifocal IOL. And we did the multifocal IOL for her, but she's not post-refractive surgery. She ended up with a quarter of myopia, and she's unhappy. And it's been a year now, and she comes every time to me, and the moment I see her name in my list, it makes my days bad already, because I know that's what is her concern. I addressed with her all the issue in terms of the enhancement, using glasses. Her main concern is the glare and halos that she is seeing right now. And I wish I can have an answer. Last visit, my decision was to exchange it with EDOF. This is, I said, now it's been a year. You are unhappy at all. You could not reach where you want. Unfortunately, this is the only thing that I can at least assure you. Maybe it's going to give you a little bit a better result, because even with correcting the quarter, I was not sure if she's still going to be happy with that. Unfortunately, she disappeared. I don't know. Maybe she was going to live with it, inshallah.
But if you will go to EDOF, if she's the type of the personality, the EDOF will make her more difficult.
Thank you very much, Prof. Abdulrahman. Now, from my experience, I started implementing the multifocals, all multifocals, which now don't exist. Now we have the trifocal, the best. That I have two things that might render the patients really very unhappy. One is the dry eye, and we tend to forget about it. And the other point is also the back of the eye, especially the macula, not macular degeneration, but epiretinal membranes. Because sometimes we miss it, in fact, and that's why OCT, pre-op OCT is very important. And a rule that I made for myself is to have a long chair time, pre-operative, with the patient, consulting him, giving options, and also studying his personality, how he is. Some of these high expectation patients, very reading between the lines, this is avoid them. Even the best of the results, they will never be correct. Now this 0.25 of myop, she will not, the halos, glare, negative, positive, it will not disappear after laser vision correction. And I think the best thing is try to get here the results, that this is what we have. And if you are not, lubrication is very important. And if not, this is the main thing, is that there is neural adaptation. But now we are talking about the first few months, only 6 months. Now this is a problem in hair psychology. And I think pushing hair to the limit of exchange, one of the best solutions, in fact.
I mean,
Better.
I totally agree with the retinal membrane. يعني, I have a patient and examined his fundus carefully, and for me that fundus was normal, was absolutely normal. He has a cataract, and he came for multifocal. He wanted multifocal. I was lucky. The technician who was doing the IOL calculation, he found that there is a little bit of discrepancy between the two eyes, and he went and did an OCT. I did not do OCT because he was a cash patient. I did not want to put a cost on him, and he found that the periretinal membrane. And I was lucky that through him, I avoided doing the multifocal, because when the retina consultant saw the patient, he said, if that patient receives multifocal, he will stick with you the rest of your life. He's never going to be happy. It's thick enough to lift the retina.
To sort of prevent the foveal depression. And this is, we used to call it, these sometimes they have 20/20 vision, but with this, because the problem is the diffraction of light, what happens with this. And this is what we call cellophane retinopathy. We used to call, even the avoid. No, avoid them. No, go for monofocal plus, for EDOF, for ELON and the other. Yes, but not trifocals or multifocals at all. And in fact, the O in the mnemonics shorter. This is how you examine the patients before presbyopic IOLs. Every letter has an exam. The O is for OCT, which is.
This will take us to the question, is it mandatory to do OCT for every cataract patient? And usually this is a question, usually it's, if the media is allowed, let's take it for discussion, if the media is allowed.
No, I think very careful on this exam, I would be low, but I think I have seen patients not satisfied. In fact, maybe there is edema. When I saw it, I said, this is difficult, but because I saw, and I think if you are not sure 100% that there is no ability, better to.
My usually answer to this argument question, if you are doing something above average of other service, or the patient is having an issue with IOL calculation or looking for perfect, you need to do all this set of exams. If the patient, as you said, personality-wise is not that much, that you will not go to sophisticated correction. These are the multifocal and trifocals IOLs depends on the geometry of the eye. You need to have a perfect geometry. Right. And if you need to reach to this, you need to run all these tests. But for the usual cases because otherwise in our regular clinic, we will be exhausting the OCT and you will.
Because I totally agree with the monofocal, you're not going to change your plan. If you are planning for monofocal, you're going to do the cataract surgery anyway. But for multifocal, you're going to change your prophylaxis. I was always looking at it at the cost effectiveness. Is it cost effective to do OCT for every patient? This patient, I was trying to save and not to cost him any money. Alhamdulillah, now, if you ask me now, I will say I will do it for any patient who is going to go for multifocal, even though I'm able to see the retina, because I'm not good enough as a retina consultant to tell. There's a chance that you'll miss it.